Hello, my name's Alex Campbell-Brown. I work in Ward 7, Queen's Hospital, Burton-on-Trent. It's an acute medical ward, so we commonly deal with people with COPD. In this video, I'm going to give you a case example of someone with COPD and how we manage their symptoms on the ward. I've changed the lady's name to Mrs. Smith. Mrs. Smith is aged 77 years old. She presented with a productive cough of green sputum, shortness of breath on movement, past medical history of arterial fibrillation, and she is a non-insulin dependent diabetic. Her social history is that she's a heavy smoker. She currently lives with her partner with no package of care, and she mobilises normally independently with a stick. Obstructive lung disease. The two contributing factors to COPD are emphysema and chronic obstructive bronchus. Asthma can also play a small part in it as well. I will touch more on emphysema and chronic bronchitis later in the video. The common signs of COPD are shortness of breath, especially on exertion or movement, wheezing, chest tightness, having to clear your throat in the morning due to excess mucus in your lungs, a chronic cough that may produce mucus and will not go away easily, blueness of the lips and fingernail beds, also known as cyanosis, frequent respiratory infections, lack of energy, unintended weight loss, and swelling of the ankles, feet or legs. Emphysema. Inside the alveoli are elastic fibres. When protease breaks down these elastic fibres, this stops alveoli from expanding properly and limits the flow of gaseous exchange. And antiprotease are normally excreted by the alveoli, but when there are too many proteases excreted by the immune cells, this causes an imbalance and this is the cause of emphysema. The cause of this breakdown is inhalation of toxins in the air, such as cigarette smoke or pollution, cigarette smoke being the main contributor. They cause an immune inflammatory response. Macrophages that are found inside your alveoli act as your cleaner, but when they detect these harmful chemicals, they secrete chemicals that cause an inflammatory response. This makes more macrophages rush to the area and more protease to be secreted as an immune response. This all aggravates the alveoli and causes damages to your cell. Bronchitis. Bronchitis is an inflammation of the bronchus tubes. These are the top half of your respiratory system that lead into your alveoli. Bronchitis symptoms are a productive cough, shortness of breath, wheezing and chest tightness. Bronchitis can be caused by a virus, pollution, smoking, and bacteria that is trapped in your airway. Normally has a recovery time of a week, but with people with chronic illnesses such as COPD, can take longer. The bronchus is coated in goblet cells. These make mucus that line the airway. Bronchitis is caused by the irritation of the goblet cells by smoking, for example, and causes the goblet cells to overproduce mucus. This causes blockages in the bronchioles and the bronchus, causing the wheezing and a productive cough. This also causes poor gaseous exchange because of the blockages in the air paths to the alveoli. Treatments for COPD. The main thing you can do when you have COPD is to stop any form of smoking if you do smoke. This will cut down COPD massively. Medications can include inhalers or other forms of medication such as tablets, in extreme cases surgery or lung transplants. Stopping smoking will stop COPD getting worse, but unfortunately the nature of COPD is once it begins it's an unstoppable disease and will progressively get worse until fatality occurs. When diagnosed with COPD, patients are often given inhalers. Inhalers deliver medicine directly into the lungs. The first inhalers often used by people with COPD is short-acting bronchodilator inhalers. These help with the immediate symptoms of feeling breathlessness. An example of one of these inhalers commonly used on the ward or in community care is salbutamol. These inhalers can only be used up to 4 times a day. The second kind of inhalers that are used are long-acting bronchodilator inhalers. These last up to 12 hours each, so should only be used twice a day. Examples of these are such as salmeterol or formoterol. If you're having frequent flare-ups of your COPD, sometimes doctors will recommend taking steroid inhalers which will bring the inflammation down or the exacerbations of the COPD. An example of an oral medication that we can take for COPD is theophylline tablets. These relax the airways. These can also have side effects, however, of feeling sick, headaches, difficulty sleeping, or noticeable pounding, fluttering, or irregular heartbeats. So it's important that you have regular blood tests if you do take these tablets. If you have a productive cough that is persistent, you can also be recommended mucolytic tablets or capsules. These help to thin the phlegm and help make it easier to be coughed up. Steroids can obviously be taken orally as well to help the exacerbations. Antibiotics are often prescribed to treat the flare-ups as well, especially if they're coughing up yellow or green phlegm, have a high temperature, a rapid heartbeat, chest pain or tightness, or feeling confused or disorientated, as these are all signs of infection. Pulmonary rehabilitation is an education program that can be prescribed by a doctor or given classes. Benefits of these classes involve psychological support, physical exercises which help you deal with the exacerbation of the COPD and breathlessness, education about COPD, and dietary advice that might help you manage your condition. Nebulizers can also be used. They work along the same lines of inhalers as they go straight into your lungs and help the exacerbation in your lungs, but are a liquid medication that is diluted. Long-term oxygen therapy is often the last resort, as it means differences in lifestyle, as you have to take a tank with you wherever you go. And also it means that you'll need the oxygen at least 16 hours a day. There's a lesser form of oxygen therapy called ambulatory oxygen therapy. This is only oxygen that is used when you move or take part in some form of physical activity. The last resort for treating COPD is surgery. These can involve, which is a procedure to remove trapped pockets of air in your lungs, lung volume reduction surgery, which stops the lungs from taking in so much oxygen and therefore oxygen getting trapped, or at last resort, lung transplant. Mrs. Smith was given antibiotics to help treat the infective cause of the COPD and help treat this productive cough. She was also given inhalers to treat the exacerbation of the COPD on movement. She stayed on the ward until the end of her antibiotics and was discharged after the course had ended. Thank you very much for watching my video. This has been an overview of COPD and how it is treated in a hospital setting.